My name's Gary Dudek. I practiced pulmonary medicine and critical care medicine beginning in 1991 through 2020. I have worked with physician extenders my entire career, and it began shortly after I finished fellowship. It was a situation in our ICU where we lost resident coverage and needed to enlist the help of a nurse practitioner, a newly minted nurse practitioner, but one who had critical care experience of 10 years before she did her nurse practitioner training. And it worked out tremendously for us. And since that time, I couldn't imagine ever practicing in an ICU environment in which I didn't have the help of either a physician assistant or a nurse practitioner, because the ones that I knew, being a nurse practitioner or physician's assistant, were second careers for these people. And their first careers had always been related to patient care, either in emergency departments or ICUs or as respiratory therapists. So they were familiar with dealing with patients who were in crisis and became very good at it. But having said that, there isn't a one that I've ever known, even those with 15 or 20 years of experience, that felt comfortable reading a chest x-ray by themselves and making important decisions on that chest x-ray. And if things were to happen in the middle of the night and chest x-rays were required, those chest x-rays were always reviewed at least with the emergency room physician before they'd even call me about what was going on. I've also had the opportunity to teach in a physician's assistant training program over the course of 4 or 5 years. And so I'm kind of familiar with the training that they received. And none of it comes close to the type of radiologic teaching that I experienced in medical school and then through 3 years of residency. So they just do not have the background to be able to do those interpretations. And I fear that those people are going to slip through the cracks if the x-rays are not reviewed by somebody with clinical experience. I spent the last 6 years in practice in a rural community in which patients often came in as having been assigned to a particular primary care physician whom they had never seen, even though they had been in the practice for 10 years or more and had always seen nurse practitioners primarily or physician's assistants. And what was even worse is they seemed to never see the same one twice. So there's no longitudinal care or, experience of providing some type of therapy and then following up to see the result of that therapy. They'd be seeing somebody different the next time. And the result of that, from my perspective, is just a boatload of referrals for consultation. If this person was referred back to the internist, 50% of the time that could have been curtailed.
Right.
But the primary care docs were overloaded with their own panel to the point that they couldn't possibly supervise the nurse practitioners or physician's assistants with any depth at all. A manpower shortage, again, I guess is what we're getting to.
It's kind of a vicious cycle. You have overburdened primary care now using NPs and PAs. They then refer to specialists more often. Now the specialists are getting burdened and they hire an NP or PA to help them out. And you see it just spirals out of control. And to me, as a primary care doctor, it always comes back to investing and having more robust primary care and preventative care services. And
Correct.
we really need to invest in properly trained people. We need to give them the right training, the tools, the time to do it, and the proper motivations, because usually prevention is not as well compensated as more aggressive intervention treatments in our system.
That's correct.
Do you feel a little nervous about, you're retired now? And of course, I always say, I'm a patient, I will be a patient, and we'll all be a patient. Do you get a little nervous about the way the system is going?
Absolutely. Absolutely. I wonder who will be around to take care of me when I can't sort of speak for myself. So it is scary. I mean, there are Is and NPs that I've known that I'd want to take care of me in the ICU because they know their limits and they know when to ask and who to ask. On the other hand, I've also known physician extenders who thought they knew it all and didn't want to hear from anybody as to their recommendations for how to treat patients. And those folks are dangerous. And and unfortunately won't become real to them until they make fatal decisions.